My name is Madalina Banarescu, and my PhD thesis is about approaches to the reconstruction of zygomaticomaxillary complex defects based on virtual surgical planning and intraoperative surgical navigation. I'm an international student. I'm from the University of Medicine and Pharmacy, Grigore T, Popa, Iasi, Romania. I'm a PhD student and also a general medicine student, and my vision is to improve the life quality of patients with oromaxillofacial defects by improving the aesthetic and functional outcomes in reconstruction techniques by applying up-to-date scientific results. We have so far 3 ongoing projects. Due to the shortage of time, I can talk more about the first 2. The first one is a systematic review and a meta-analysis, and we are investigating the effectiveness of intraoperative surgical navigation over conventional surgery in the management of zygomaticomaxillary complex fractures. As a bit of a background, we can see there are a few number of cases of facial fractures each year globally, and the prevalence of zygomaticomaxillary complex fractures is 28.3%, and the pretty high number of these patients have a remaining mid-facial deformity after conventional surgical treatment. So this is why we aim to assess the accuracy in treating zygomaticomaxillary complex fractures using intraoperative surgical navigation system. Our clinical question was that if intraoperative surgical navigation can be more effective in treating zygomaticomaxillary complex fractures, we used the PICO format, and we compared the fractures treated by unassisted intraoperative surgical navigation system or without one. And as a primary outcome, we measured the accuracy, and the secondary outcomes were operative time, mouth opening, amount of bleeding, hospital stay, and cheek numbness. And our hypothesis was that intraoperative surgical navigation would be more effective than conventional surgery. Here you can see the systematic search that we did in 3 databases and the domain we used. And this is our flowchart of selection, and in the end, we had 5 full-text eligible articles to include in the meta-analysis. I'd like to show you my results. First of all, most of our results would be presented in mean differences measured in millimeters. The first 2 figures measure the accuracy of the most prominent point of the zygomaticomaxillary complex fracture and also the accuracy at the level of infraorbital rim. We measured the accuracy at these levels because the most prominent point is considered to be to have a big defining result in the aesthetics of the patient, and also the infraorbital rim. Because these fractures are often associated with orbital fractures and orbital volumes reduction, we need to measure also this point. But as you can see, neither in the most prominent point or the infraorbital rim, we didn't see any significant difference between the navigation-guided group and the conventional group. In the third figure, we measured the average deviation of the zygomaticomaxillary complex fracture. This time it was a 3-dimensional measurement. So basically what the studies did was that they compared the post-operative result, and they superimposed the image with the healthy side of the patients, and they measured the average deviation. And this time, as you can see, it was a significant difference between the navigation group and the conventional group. However, it is pretty hard to say if this statistically significant difference is also a clinically relevant difference. We also measured the operative time between the 2 groups. We expected that in the navigation-guided system, the operative time would be reduced compared to the conventional surgery, but we had no difference between the 2 groups again. We also measured the maximum mouth opening between the two groups because it is quietly encountered that in the zygomaticomaxillary complex fractures we have a limitation in the mouth opening, so it is also important to measure that. However, there was also no difference between the two groups. This is the most comprehensive meta-analysis on intraoperative surgical navigation in treating zygomaticomaxillary complex fractures. We investigated multiple outcomes and we did multiple accuracy analysis, but also we had small number of studies. We couldn't include any measurement for the soft tissue, and the studies also included multiple types of fractures. We can say that intraoperative surgical navigation could improve postoperative average deviation. However, we found no significant difference in the accuracy of the most prominent and infraorbital point, the operative time, and maximum mouth opening. For practice, we can say that intraoperative surgical navigation could be more useful in the cases of more severe fractures. It can be useful for the young surgeon, but also we need to take into consideration the learning curve that the practitioners need for this kind of system. And for research, when when investigating this type of fracture, we should investigate them separately by their severity. We need to measure the time using this intraoperative surgical navigation system during the operation. We also need to measure the orbital volume because these fractures are also associated with orbital fractures. We need preoperative measurements of the maximum mouth opening, and we also need to measure the soft tissue accuracy. Currently, the manuscript is under revision in the Journal of Cranio-Maxillofacial Surgery. The second study, we'd like to investigate the effectiveness of intraoperative surgical navigation over conventional surgery, this time in the management of orbital reconstruction. It's also a systematic review and a meta-analysis. We wanted to investigate also the orbital reconstruction because in the first study we wanted to pick as an outcome also the orbital volume, but the studies didn't measure that. So this is why we went to the orbital reconstruction to be able to study also the orbital volume. So we know the prevalence of orbital wall fractures are between 18 and 50% in all cases of cranio-maxillofacial trauma. And the orbital reconstruction is a challenging task, and the postoperative complications are pretty costly. So this is why we aim to investigate the clinical outcomes of orbital reconstruction assisted by ISN. We also use the PICO format, and our question is that if intraoperative surgical navigation can achieve better clinical outcomes than the conventional technique. As a primary outcome, this time we chose the orbital volume, but we also want to measure the implant accuracy, the operative time, and the complications such as diplopia, enophtalmus, and the rate of revision surgery. And our hypothesis is that intraoperative surgical navigation can achieve better clinical outcomes than the conventional technique. And by this, we would like to achieve better functional and aesthetic results, reduce the operative time, and reduce also the rate of surgery. Here you can see the preliminary search, and this project is still in the early phases. Here you can see the summary of our project. The first project was submitted last month, and now we can focus on the second and the third topic. Thank you for your attention.
Thank you, Madalina. This is really a good topic for oral surgeons, I think. So we will get some questions. I mean, before that, just in very general, I mean, that is also for the committee. I mean, Madalina is an international student, so we actually have a joint PhD program with Iasi University, and then for this reason, actually, we have a Hungarian and the Romanian actually supervisor, and that went on very well. The danger now, as you have one paper, is that, and then you do other things, since she was obliged to stay here in Hungary for 1 full year, and then the remaining 3 years are going on in actually via Zoom and other kind of similar kind of ways of communications. So the big danger is that whether you can focus to your second study, so you can really kind of progress with those. So how do you see this? I mean, so I just put upside down the things, and instead of asking this at the end, I mean, we should see that at the beginning. That applies not only to you, but that applies to other fellows too, that who actually in this kind of individual group, I would say, and then had one paper, and then just postponing and postponing the second one.
Yes, it is a good question. But I think the answer is not that complicated. It's not like I have any choice. I have to focus also on the second project and also on the third project, because from what I understand, here at CTM you need at least 2 published articles, but back home in Romania we need at least 3. So
That's fine for us. I mean,
yes.
you do not worry.
So, well, it's a bit hard with also starting the general medicine and the residency and the PhD, but...
Okay, so keep going. How expensive is this navigation system? Because you said, I mean, that is actually more or less have the same kind of outcome as the conventional.
Yeah, I think it depends it depends on the producer. I think they are 2 or 3 big producers. I think one of them is Brain Lab. Then it's another one. It's the Colibri system. I think they are somewhere. They range from 50,000 euros and 100,000 euros per system. I think somewhere around that. Because you don't need only the navigation system, you need also the base platform that can be used with also other system, not only the intraoperative surgical navigation, but most of the times the base system costs are pretty high.
So one investment. Do you have that system actually at home in Iasi?
In Iasi, we have this system only in the neurosurgery department, so not in the maxillofacial department. But from what I know, there is only one system like this in Iasi, and it's mostly used for neurosurgery.
Yeah, I mean, this is not in your own hands, but of course, I mean, that's a very important kind of task for the translational medicine system. I mean, that what we actually explore in a certain direction, and hopefully that goes to clinical practice.
The plan is in the future to also bring this system in the maxillofacial department.
Yeah. Questions, please.
I'll have one. Thank you for your presentation. It was very nice. My question is, we could see that there is a tendency for achieving better results with the navigational technique. But my question is regarding the control of the conventional group. How heterogeneous was that? Was it only one or multiple surgery techniques involved, or the fixation of the bones are the same, or there is some difference between the techniques, or what can you say about this group?
Thank you. Indeed, we noticed a tendency towards the navigation system achieving better results. But the problem with the groups were, first of all, they included 2 types of fractures, and they didn't investigate them separately. So they included type B zygomaticomaxillary fractures and type C. The type C are the comminuted fractures, and type B are a bit less severe. So they investigated them together. And for example, we had one article, which was also an RCT, the only RCT that we could find. And they only investigated type C fractures, the more severe fractures, and that was the only study that had significant improvement in results while using the intraoperative surgical system. But besides that, the operation technique was pretty much the same. But another thing that they didn't mention in the articles was how experienced was the surgeon using the intraoperative navigation system, because this matters a lot. For example, we found articles that stated that first times when using the navigation system, you tend to check more your work, but as you get used to the system, you check it a bit less, so it takes you a bit less time, and also the operation time is reduced.
Thank you for your answer.
Thank you for your presentation. I also have a question regarding your project. First of all, you said in your background that with the conventional technique, the biggest problem is the mid-face deformity. So
Yes.
it's like an aesthetic problem, and how does this, with your findings, can be improved? And the second question is, you said that the intraoperative navigation should be implicated in Romania. And why is that the case? Because in your results in the first project, there didn't seem to have clinically relevance for your outcomes.
Okay, so thank you. Let me answer your first question. Can you repeat it, please?
My first question was, you said in your background the problem with the conventional technique is that...
Yes, I remember, thank you. So by mid-facial deformity, we mean that the patient aesthetics is affected mostly. We don't have so many cases in which after zygomaticomaxillary fracture treatment, the patients remain with a functional defect, but they mostly remain with the aesthetic one. So this is the main problem. And we have, for example, many cases in our hospital of patients that come from different regions with dissatisfaction with aesthetics after the zygomaticomaxillary fracture treatment. So this is why we would, and the problem with this is the first time you treat a you reduce a fracture, it's one thing. But when a patient comes after for a second treatment, a second intervention, then it's much more difficult. So this is the place where the intraoperative surgical navigation can help you the most. And also, we would need this system in our hospital, and we want it in our hospital, also because it can help young surgeons be more familiarized with this intervention, because they have something to base their surgical technique in real time when doing the intervention. Right now, you need pretty much experience to do this kind of surgery. So it's not the easiest one, but while using the intraoperative surgical navigation, it can become easier, and you can learn it in a much less period of time than you would without it. And can you remind me your second question now?
The second question you already answered,
Oh,
so why
okay.
you want to bring it. But so did the articles actually said that the aesthetic could be improved with the intraoperative navigation?
The aesthetic is a bit of a problem because, as we said, we did measure the accuracy at the bone level, but the aesthetic is also influenced by the soft tissue. And the articles that we included, they didn't measure any soft tissue related outcome. You can say that by achieving good accuracy at the bone level, you usually get the aesthetic result, but it also depends on the soft tissue of the patient, because when you have, let's say, a skinnier patient, the deviation that modifies his aesthetics would be much lower than a one who has, for example, a more soft tissue to cover the bone defect. So we would like in our third study, we would like to come up with a method for measuring the soft tissue also.
Right, thank you.
Thank you.
Thank you very much. I'm not a professional, but like these results, you have also mentioned that these are not clinically relevant, like this below 0.5 millimeters. I mean, that's barely visible. So if they were to mirror actually my healthy bone structure, maybe like these 2 points would actually...
So they say that
yes.
A clinically visible difference would be more than 2 millimeters. But that's why I said that we are not sure, we can't say for sure that these are also clinically relevant.
Yes.
But it also depends on the soft tissue as well.
Yes, and that's what from this stems my second question. Like seemingly you had 5 articles, maybe only 5 because they saw that, okay, there's not much of a difference between navigation and conventional. So if you have the gut feeling that this navigational system is actually working, what would be your ideal study to actually detect the effect of navigation? Like if you had like endless amount of money and resources and stuff.
That is a great question. Thank you. So I think in the first place, it would need to be an RCT.
Yes.
But it would take a very long time because we basically need to wait for patients to have a specific kind of fracture. We would separate the type C fracture and the type B fracture. We would need a pretty high number of patients. I think it would be, to be a reasonable study, we would need at least 40 or 50 patients with type B and type C. And the type C are the fractures that are a bit rarer than the type B. We would need 1 surgeon to perform, or 2 surgeons maximum to perform all the intervention. And both of them to be, I'm not sure if it's a reasonable number, but from my point of view, I think they would need at least 5 years of experience using this system to be able to also, for example, analyze the operating time and to be able to say, yes, we need more time with the conventional surgery, or no, we need more time with the intraoperative surgical system navigation, or there is no significant difference, so it doesn't improve time. But we need to have experience, because if you give me this intraoperative surgical navigation, I would probably look at the screen once every 10 minutes. But an experienced one would maybe look at the end of the intervention to check it, or maybe twice. So it's already less time using the navigation system, so less time in the operating room.
Excellent. I hope you're planning on a future in research. Thank you very much.
It would be great, thank you.
Congratulations, Madalina, and thank you for your presentation. I have 2 questions. And the first one is, how many time can this technique save in the surgery? And the second one is, you mentioned the learning curve as the implication for practice, and I'd like to know how can it be measured in the clinical practice?
Okay, thank you. Can you remind me the first question? I'm sorry, I was focusing on the second one.
How many time it can save?
It depends on the literature. We found articles that said that they can reduce the operative time by 10%. and also articles that said that they it improves the operative time by 25%. So it probably depends also on the type of intervention. There are not so many articles of intraoperative surgical navigation. It was first used for neurosurgery, so it recently came into attention of the oromaxillofacial surgeons. So we mainly have articles for orbital, using this navigation system in the orbital fractures, and now we extended its use. So we still need a bit more time to be able to say how much time can actually be saved using this navigation system. And well, of course, more studies. Now tell me again, please, the second question.
It's regarding your implication for practice. You mentioned the learning curve, and I'd like to know how can it be measured in the clinical practice?
Well, I think, I'm not sure this is the correct answer, but I think one way of measuring the learning curve is by having an experienced surgeon doing, for example, one intervention and having his time, and then one young surgeon who starts doing the same intervention with the same navigation system, and you can see in how much time does he needs to approach the time of the experienced surgeon, because it would take like many years to approach the time of the experienced one, but at least the time to reach a plateau. I think this would be one method of measuring the learning curve.
Thank you.
Thank you.
Yeah, thank you for your paper. This is the most common fracture in our field. We are deal with this almost every day. We are really together. And about the learning curve, because the intraoperative navigation surgery is the highest level of the advantage about the approaches for more complex fractures. But sometimes you can have this kind of fracture really easily to solve with one movement with the hook without any incision. And the learning curve could be probably compare, maybe this is the answer for your question, how she can compare accuracy with the CAD/CAM techniques and planning of the guided surgical splints. And that means that you can prepare to the software mirroring and try to use the opposite side, which is healthy. And then you can create the guide, the surgical guide, and then it can help you to put the bone together in the proper position. And you don't need the navigation intraoperative system. So it's a good thing, but it's really, really expensive. You need the skill set. And maybe this could be answer. How can you compare the CAD/CAM technique and pre-plans with the navigation surgery?
Thank you. In our studies, in the groups that were using the intraoperative surgical navigation system, they actually did the virtual surgical planning before by using the mirroring technique, and they used this plan and they uploaded into the navigation system, and this was their comparison, and this is what they used during the intervention. So it's not only the navigation system, but you also have the virtual surgical planning done before, similar to the surgical guides. But it would be interesting to compare the intraoperative surgical navigation with the surgical guides to see if it is feasible, let's say, to acquire such system when you can use the surgical guides.
I have only a small comment. So you decrease your merit because as an editor of the Cranio-Maxillofacial Surgery journal, the impact factor is higher, 3.1. So that was written falsely.
Okay, thank you. Thank you.
All right. Any more questions? I think we are set well. So, just this is not the end. This is the main message from the committee and also from CTM. But otherwise, thank you very much.
Thank you.